I'm going to talk tonight about bipolar disorder. That's my specialty. So I'm going to talk to you about what bipolar disorder is, what mood is, what a mood disorder is. I'm going to talk about my research, but also what to do if you are bipolar, or if you have a relative with bipolar, what to do when you know you cannot reach your doctor, there is you're in crisis, how to detect those subtle signs of getting sick, and what to do about that. So let's get started. First, I'm going to start by describing what's mood, what's bipolar disorder, what's depression, what's mania. Then we're going to talk about how mood is regulated and why it's important to understand the techniques or the things in our body that help us be happy or sad, because sadness is not such a bad thing, as you will see. And we'll also understand some of my research is related to more mathematical modeling, so we'll know what entropy is and why understanding that part is important in bipolar patients. So let's start with mood and emotions. An emotion is something that you feel when you get really angry, for example, in traffic, or something very short-lived. You can be fearful as well, that's also an emotion. They don't last long. That's the main difference between mood and emotions. Mood is longer lasting, and usually when your doctor asks you, how do you feel today, you will be answering, thinking about your emotions and your mood. Mood is usually what you say, how you are feeling. So bipolar disorder is a mood disorder. It's a type of mood disorder. There are many types of mood disorders. Mostly the most commonly known is major depression, and another type is bipolar disorder. So being bipolar means that you have episodes of depression and mania or hypomania and mixed episodes. Being bipolar doesn't mean that your mood changes quickly or that you are happy one day and unhappy the other day. I'm going to talk about that later, but being bipolar is a condition that has discrete episodes of depression, mania, or hypomania. Sometimes they get combined in a very complex clinical picture called mixed episodes. Mixed episodes means having depression and mania or hypomania at the same time. So you would feel, for example, like you're super irritable, very angry, you want to punch the wall, but you want to cry, for example. Or you are very, very tired, but at the same time your mind is racing. So having all those symptoms at the same time means that you are having a mixed episode. It's a bit more complex than what I'm describing here, but in general, mixed episodes belong to a type of bipolar called 1, as well as manic episodes, and hypomanic episodes belong to a type called 2. Both types have depression. That's the main burden of the illness, because people with bipolar disorder will have years of depression, either a really, really long depressive episode or very frequent depressive episodes. Manias or hypomanias, in most of the cases, are not that frequent, but they can be very detrimental. This is a kind of an old picture, an old concept about bipolar disorder. Euthymia means when someone is stable. When someone has no episodes, he or she is not depressed, no mania, not hypomania, but you see this kind of flat line, it's never like that. If you think about your own mood, you cannot be happy every day, or you cannot be like, nothing is happening and you're always kind of flat. That's impossible. You always react to what's happening around you. So euthymia will have probably minor fluctuations, not as marked as these ones, but tiny minor fluctuations, and that's pretty normal. Again, bipolar disorder it has cycles. So for example, most of the patients, as you will see later, they have an index episode. That means that they will start with a depression. And then the problem starts because there is no real way for us to tell what is going to be bipolar and what is going to be major depression if both look the same at the very, very start of the illness. We have now some clues, and I'm going to tell you that later, but the problem is that patients with bipolar, if they present with depression and your GP gives you antidepressants, for example, it's very unlikely for people to respond to antidepressants. They can actually get worse on antidepressants, not only because they can switch to hypomania or mania, but also because antidepressants can chronify depression. It will make it worse, longer, or more severe. So what's known about bipolar disorder? How does someone get bipolar disorder? And it's a question that I get often. So one of the main important factors is genetics. That means that there is not one single gene that will tell you, oh, this gene or in the chromosome 2, for example, will define if you are bipolar or not. No. This disorder is called polygenic. That means that there are different parts of several genes that when combined will give rise to a mood disorder. There are other factors in your family history that when you present it to your GP or to your psychiatrist, if you are depressed, people can start thinking maybe this is not only major depression, maybe this is a bipolar illness. And those are, for example, family history of bipolar. If in your family there is someone with bipolar disorder, it doesn't mean that you will have bipolar 2 or your children will have it. No, it only means that the risk for you to have a mood disorder is higher. There is another good, let's say, clue, family history of psychosis or family history of suicide. Those two factors talk about a very severe depression. So if you combine the history in your family of, let's say, my aunt was bipolar, and then my cousin is depressed, and there was an uncle with who committed suicide, then you start thinking that maybe this patient is not only, even though he's only showing signs of depression, maybe I should also keep in mind that this could be a bipolar illness. Other factors is the age at onset. This is a graph of a paper we published a few years ago. So bipolar starts early on. It's very difficult for someone to be diagnosed with bipolar at 60, just out of the blue. You have to dig in really, really, really deeply. So one of the most important factors in terms of age at onset is that it's really early on. As you can see, early, around teens or so, about 20, people start having usually depressive episodes, usually combined with stressors like moving or going to a new school, for example. It's a rough period. But there are authors that suggest that some of the signs of bipolar are seen earlier, and one of the main ones is a sleep disruption in children. So children tend not to sleep well in those families with bipolar illness. That's one of the early markers of the illness. That's still part of a research study, but it looks very promising. Other stressors, of course, in terms of positive or negative stressors, getting married is nice, but it's a stressor. Getting promoted is nice, but it's also a stressor. Moving or going through a divorce is very stressful. All these stressors, which amount to a great deal of, it's just too heavy for someone to carry in someone who already has a very fragile system, can function as a trigger for an episode, either depressive or manic. Other factors could be medications, and these are, for example, and I'm not talking about drug induced, that's a completely different story, but of course drugs can induce psychosis or mania or depression, but certain medications in someone who has the possibility of being bipolar can trigger episodes. For example, thyroid hormones, that's why people have to be very careful about them. Steroids are another one. In general, if you prescribe steroids for a short period of time, that should be okay. But in people with bipolar disorder, there is always the concern of bringing a hypomanic or a manic episode if someone is taking steroids. Even antibiotics. Sometimes antibiotics in people with bipolar, you'll see that for at least a couple of weeks when they are on them, or 2 weeks after they stop them, they notice their mood was not that well, a bit more tearful, a bit irritable. That also has to do with theories related to the inflammation and bipolar disorder. And of course, there are other comorbid conditions that point us towards a bipolar diagnosis when someone is only presenting with depressive symptoms. And that could be migraine. Migraine is it's highly comorbid in people with bipolar disorder. Also cardiovascular disease, as well as anxiety disorders. By anxiety, I mean generalized anxiety, panic attacks, social phobia, for example. So let's talk a bit about the symptoms of bipolar disorder, starting with a depression. So depression is more than feeling sad. We can all feel sad, and it's pretty normal. When someone passes away in your family, grieving is completely normal. The problem with depression is that you have 2 weeks of a change. People notice that you are not the same and you cannot function. There is a change in your function. Let's say that you go to school and you just feel like you're going to stay in bed all day long. You don't have the energy to get up. You cannot even concentrate. You fail your exams, for example. You cannot sleep at night. You are not eating much. You have all these physical symptoms, for example, headaches, or you are just achy. You're feeling like you're going to get the flu. But also, the main change is in your mood and in your cognition. You feel sad, you feel empty, you feel like you're not enjoying anything, you don't want to go out. You see, like, there is no reason to celebrate my birthday. What's the point? More severe cases will have psychotic symptoms, for example, hearing voices or feeling like someone is after them. And severe cases will also have suicidal ideation or thoughts of death. A manic episode, I'm going to describe a manic episode which is similar to hypomanic episodes, but hypomania is less intense than a mania. Manic episode this one lasts for about a week or more. Again, this means that people are different from their baseline. At the very, very early signs, they're usually difficult to recognize. So usually the first one who will say, "Are you feeling okay?" are your father, your mother, your husband, your wife, for example. And one of the first signs is sleep. So people with hypomania or mania, they will feel like, I can go to the gym twice a day, and I need maybe 4 or 5 hours of sleep. My normal is 8, but I'm not tired and I just want to go. And I thought about a different idea, and maybe I will open my own business, and I have so much energy that I talk very fast, but I'm really annoyed by people. If they cannot keep up with me, for example, they don't understand me, they don't understand that this is important. This mania, or these symptoms keep increasing, they can become potentially dangerous, of course, because then people can develop psychosis. That means I'm the smartest and I'm the strongest, so I can, just start a war. I'm gonna go into Parliament Hill, and people can actually try to do those things. The problem is that they end up then in having problems with the law, where their main issue is mental health. So mood regulation, this is our second topic. I said why we cannot be happy all the time. So imagine, this is an image I like because it's supposed to be a forest, like a bamboo forest. And bamboo bends and moves and changes, but it doesn't break. So that's the key to understand mood regulation. This is the main focus of my research. And I think, again, if you look into nature, you're going to find a lot of the answers. The reason I'm putting here this picture is because mood I can be conceived as a system that's very flexible. In a dynamic system, in a healthy system, in a flexible system, you can bend, but you don't break. So yes, someone passed away in your family, you can bend, you can get sad, but then you bounce back, right? So it's always, it's a complex process, and it has to do a lot with your culture, with your age, with the way you conceive the world. But in general, the nice thing about mood regulation, as any other health or process in our body, has to do with change and movement. If these changes, or if this system is not that flexible, if it's more rigid, then it cannot engage in proper response. Let's say there is a divorce in the family, and then you try to bounce back, but there there is no one there to help you, you don't feel like talking to anybody, and then the winter comes and you don't feel like going out because it's super dark and super cold. So that system, instead of becoming inflexible and trying to bounce back, is going to become more rigid and less flexible. So this theory about the flexibility and change comes from chaos theory. Now, I'm not a physicist, but I'm interested in mathematics and physics. And there are a few techniques that can help us understand what mood is if we, let's say, if we use what mathematics and physics have been using for years. One of these techniques, one of them, it's a group of techniques, they are called nonlinear. And that sounds like a really complicated process. It's not that complicated. Think about the weather. I don't know if I pronounce it properly, but this is supposed to be a graph of the weather. So think about the seasons we have here in Canada. I was born in Mexico, so really there are not many seasons. There is only one season in Mexico. So coming to Canada was a bit like an eye-opener. But when you check, let's say, the Weather Channel, and you see today is going to be -10, and tomorrow is going to be -8, and then you see the changes. So it's not like today is -10 and tomorrow will be 30. No, it's not like that. The changes happen, but also there is kind of a flow to those changes. They're not abrupt, and they're not like, I told you Earth to be warmer tomorrow. It changes as a function of time. So that's an explanation, a very simple explanation of why we can understand mood using this analogy to the weather. Now there is something called entropy. And entropy also comes from physics and mathematics. Entropy is a measure. You can measure the amount of noise in a system. That means that if you remember your biology classes, let me see if I have it here. With entropy, you can measure what's regular and what's not regular. Here, I try to say this is the department of entropy, and it's like there is no order at all in this department. But what I want you to remember from entropy is that higher levels of entropy are related to healthy states, more change, more movement. Lower levels of entropy are related to illness. And I'm going to show you a few images of that. This is, again, a very simple picture to understand entropy. Something highly ordered will have lower entropy levels compared to something that's more disordered, which will have larger entropy levels. I'm not talking here about chaos because that will be a different topic, but in this sense, the take-home message is that for entropy, higher levels are good. Lower levels are not that good. This is a study, I don't know if you can see it in the back, but this is a study that was done in men over, starting when they were 20 years old, all the way until 80, and they were measuring their heart rate. APEN means it's a type of entropy, approximate entropy. So you can see here that it went down, 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 the older we were. So again, this study is very old, so it was showing that healthy states relate to higher levels of entropy. So young people will have a lot of movement, a lot of variability, lots of changes. As you grow older, those changes start to decrease. They're more organized. So what if we can do the same in mood? So we thought if we have this concept, let's say, and we can understand the weather about, we can understand what the weather is about using entropy, for example, or time series, and there are studies about heart rate, what happens in mood. So we wanted to see if entropy, that measurement, was different in people with bipolar disorder, with healthy controls, or healthy relatives or people with bipolar disorder. This is a scale that we used. It's a very simple scale. It goes from 1 to 9, and 5 is your normal. So it's always difficult to define what your normal is, but remember what I tell my patients is that before getting sick or when you are really, really well, that's your 5. When you can function at work, when you go to school, when it's not difficult to focus, when you can perform, it doesn't mean that you'll be perfect, super happy every day, but it's your usual self. Lower than that would be sadness or fatigue. Higher than 5 would be more activated, more energy, more anxiety, for example. So our groups filled out all that scale for about 3 months. And this is the graph that we, from the results we got from the healthy group. So these guys were usually around 20, 25. We have 30 healthy controls, no family history of bipolar, no family history of depression. And this is how their mood, their anxiety, and their energy looks like. So let's focus on their mood. It has like a bell shape, right? All these three have the same. So it's pretty normal. That means it's like a normal distribution. These ones, these are the bipolar cases. Again, 30 patients did this, fill out the scale twice a day, every day for 3 months. And you see it looks the same. It's kind of the same shape, pretty normal. And their healthy relatives, those who have a family member with bipolar but who were not depressed or anxious or had never had any psychiatric symptom, when they fill this out, it looks exactly the same, kind of the same bell shape. So nothing different, the three groups show the same results, but then we thought, now it's time to apply our time series analysis. And this is the comparison that we got. So here on the left are the healthy controls, and here are the bipolar patients. And you can pay attention to the middle graph. So you see how in the healthy controls, the changes are larger compared to bipolar patients. So the graph looks a bit more disordered on this side than on this side. This is another picture of that. This looks very, very, very steady, not much change. This is a patient with bipolar disorder, probably having a depressive episode here, recovering more or less here, depressed again, but you see how there is not much change. This is one of the unaffected relatives. That means it looks very similar, doesn't it? So really no major change. So the other part of my study is related to your heart. So heart disease is in general a major problem in our culture, but this is particularly bad in bipolar patients or in mood disorder patients or in patients with schizophrenia. And the reason is that we don't know why is that. People have tried, they have a lot of theories about it. You know, some people say it's because of the medications, and then the studies came, from last century, finding the same cardiac problems even before medication was started. Some people say it's lifestyle, if people smoke, it's going to be even worse. Yes, it's true, lifestyle has a major contribution, but it cannot be the only factor, because even in people who are not smokers or who exercise, but who have bipolar disorder or schizophrenia, the rates of cardiac disease are higher compared to the general population. The other, and I'm sure you've heard that depression can break your heart. So depression, when people get sad, then people can have cardiac events or heart attacks. But also when people have heart attacks, they can also get depressed afterwards, and actually treating that depression is difficult. The problem is that if we want to study heart disease in bipolar disorder, we really have to study only bipolar illness. The thing is that if you have depressive population, how do you know who's bipolar and who's only unipolar or major depression? It's a very difficult question. So what we are starting to do is to really characterize those who are bipolar and see how their heart is. And we do that because my question is, I think emotions are not only in our brains. I think the way we feel about our mood, our emotions can reflect in many of our organs, not only here, but I think our heart is one of the major ones. So for example, the questions that I ask is, let's think about your heart rate. If you are angry, if you are fearful, your heart rate, your heart will pump really, really fast. If you are sleeping, if you are calm, you don't even notice, right? But what happens if you are in an episode, let's say, if you are depressed, or if you are manic or hypomanic, or if you are stable, do you think your heart will notice? Do you think your heart will change? Let's say that, yes, it will notice. What will happen once you recover? What will happen if you are in a depressive episode and then you are back to your normal self? Will your heart rate also change? So we call this study the heart rate variability study, and we do this using, I think, something very useful. It's a wearable. So it's like a shirt, like a very thin shirt, like the ones you would use to go to the gym, but it has a lot of sensors. So you can use one of these, it's like the sensors you use here, you put it here, like a little bit under your ribs, and then this will monitor your heart rate for about 24 hours. In that period, we'll also measure like how well are you sleeping. Maybe you went to the gym, maybe you didn't go to the gym, maybe you have a cold, maybe your diet changed. So we measure all the variables that can have an impact on your heart rate on that day. And we also have some blood work, mostly to check your sugars and your cholesterol. This activity index is a scale that we use because, let's say you have a super high-level athlete. They will have very different variables compared to someone who's not exercising. So we have to measure how active you are to make sure that we have a good idea of how your heart health is. So I wore it, and this is my data. If you want to check it out. I wore it, and I think I went to the gym that day because look, it's very, very high, but you see the changes here. You have a few peaks, and here, and it changes here. Here, sometimes it's higher, sometimes it's lower. The same here, when this is R to R is an interval between heartbeats. It changes quite a bit. Same thing that we did with the mood rating scale. You see the same kind of bell curve. It's called, again, this is having a normal distribution. It's pretty okay. My mean heart rate is around 950. So it looks like my heart is okay. What will happen if someone is depressed? This is something that we are considering. What will happen in someone who's bipolar and who's having mania or hypomania or depression? This is an example of what we think will happen. There is not much change here. If you can see, this line is a little bit flat, and there is no bell-shaped curve. And here, the mean RR interval, mine was 950. This is a bit lower than that. So we have an hypothesis that yes, your heart rate will change when you are depressed, but what will happen when you recover? And that's why we do this study, asking patients to have measurements when they are fine, let's say, or if they get depressed, we measure them again. The idea is that I want to convey the message to my colleagues, to other physicians, that yes, it's very important to take care of your moods, of your medications, but also don't forget to take care of your heart, of your metabolic system, of your sugars, for example. And I would like to take this message also to the cardiologists, for example, because I think if we work together, we can make a difference. Here is some preliminary data about the studies. For example, again, using the wearable, we wanted to see if there was a correlation between how long a depressive episode was and your heart rate variability. And here you see this line is going down and down and down. So the longer the depression is, the more your heart will suffer, the less variability you will have. Again, the same thing with illness duration. So this is not only with depressive episodes. This has to do with how long have you had bipolar illness, for example, or how many untreated episodes have you had. And here you see the same picture. The line is going down. So the longer your illness duration, the lower variability your heart will show. That's why I think we need to implement actions sooner than later. This is like a preliminary picture because our studies are ongoing. So what do we need to do more about your heart studies? So we need to increase the sample size, complete it, compare different types of episodes. We're developing an app to collect electronically your data, your mood. So my idea would be, because I cannot be everywhere, but if I can see the data that someone is sending through the app, and then I can use the tools that I was telling you about, like time series analysis or entropy calculations, to forecast if someone is going to be sick, if someone is going to get depressed or hypomanic, then I will be able to intervene earlier. because once the full episode, the full-blown episode is there, it's harder to treat than when you have early warning signs or an idea of how to work with your symptoms. And the other part is about the mood series. I'm also interested in knowing how quickly our mood changes, and there is a diagnosis in our classification called borderline personality disorder or traits. Some people with this problem will have very, very quick mood swings. Usually depends on the stressors, but it would be interesting to see how quickly their mood changes and how different it is from people who have bipolar disorder. People with borderline will get depressed as well, but the depression is very different. So that's why I think going deep into the symptoms will make for a better diagnosis, instead of just grouping everything into one big depression, when the case may be very, very different. Now, my last part of the conversations will have to do with how to help if your relative has a diagnosis of bipolar disorder. So I divided these in two groups because the strategies are different. Let's say that someone is in a depressive episode. So you will, if you know me, then you see I'll repeat things over and over, but when you get depressed, it's very, very difficult even to get up and to function and to go to work. Sometimes it's even difficult, to have a reason for living. So in depression, that's when you need support the most. So one of the things that's very useful is routine. So I know you don't want to get up, I know you hate it, and I know you don't use alarm clocks, but you need to get up at the same time every day, in winter or in summer, or if it's dark and if it's rainy, it doesn't matter, because routine will be helpful. It takes away that I have to do it and you think about it and I don't want to. It's automatic and you have to do it. Another technique very useful is the light lamp. Light lamp is it's called light therapy. So in the winter, or let's say in early, like at the end of October, when the day starts getting shorter, our brain will notice, of course, and that will trigger a change in one of our hormones. It's the change that mammals will identify like a signal to hibernate. We don't hibernate, but people with bipolar will get very sensitive to changes in light, for example, or when they travel to Europe. Jet lag is particularly rough. So in winter, if you have someone who's depressed, the light therapy is very useful. And you have to use it really 20, 30 minutes per day. As soon as you wake up, you can read the newspaper, you can have breakfast, you can do anything in front of the light. That will be tricking your brain into telling him, no, it's not winter. No, I'm not going to hibernate. And then you keep going. Another technique that's usually tried in inpatients unit, but people can try modifications of it. It's called sleep deprivation. If you have, and let's say that you have, if you went to a really good party and you didn't sleep much, the day after, you remember how you feel, and not hungover or anything like that, just tired, but not sad. So the same principle applies when you have someone who's depressed, and if all you want to do is sleep, that's only going to worsen your depression. So the point is, sleep deprivation is in keeping with the routine. So you get up at the same time and you go to bed at the same time, and if you can shorten a little bit the amount of time you're sleeping, that will be very helpful. It's a very potent antidepressant, per se. The other part to prevent, for example, getting depressed, we are all stressed out. Everything is stressful these days. I don't know how we don't meditate more often, but physical activity will help you quite a bit, not only with in terms of getting out of the depressive episode, but it will also help you just trying to control or decrease the detrimental side effects of stress, per se. So you'll have all these endorphins in your body. You will also help your heart, but you will also help your mood. By small wins every day, I mean that. By that, I mean when you get depressed, you feel like everything takes so much energy, even making your bed, talking to people. I saw someone, for example, who was very sick after having a baby, and she had so much fatigue that she told me I couldn't even remember how to walk. So she reminded herself, you used to walk, so 1 feet after the other. It was so painful. Her baby was just a newborn, but she was so depressed that it's heartbreaking, really, to see someone that depressed. By small wins every day, I mean that even though if you feel depressed, you will feel that everything is a huge problem and I don't even want to think about talking to my boss because no one will understand what I'm going through. Okay, you don't have to do that. It's not that big. So you have to decrease the amount or the size of the problem. By that I mean, today I'll wake up at the same time and I'll make my bed. And that's a win. And that's a win, and that's all I want, just small wins every day. If you have this expectation of tomorrow I'm gonna be back to normal and I'm gonna catch up, you're gonna feel worse. So you're gonna have small wins every day so that you'll feel empowered. Like you can do something about this illness. It's not that it's taking control over me. You can do something about it too. And of course, knowing your early signs of relapse is very good. Talking to someone, a few years ago, I think a journalist asked me, she had a friend with bipolar, and she told me, I see she's getting depressed, but she doesn't want to text, she's not answering the phone. What do I do? So exactly those are the moments when people need you the most. So if you have someone with bipolar who's depressed, just try to be close to them. You know them, they trust you. They don't have to, you don't have to save them. Let's say you don't have to save the world, but you can understand that it's so painful for them to ask for help. Sometimes just because of all the stigma that's unfortunately still in place, but also because people feel like they are a burden when they are not. So be close to them, even go for a walk. Yes, you are busy, I'm busy, we're all busy, but we'll make the time. So small wins again. Keeping the structure in place, and of course making sure they have a healthcare professional in place. That's for the depressive part. What to do with the mania or hypomania? This is a bit tricky because people who have bipolar like to be hypomanic. The mania is not that pleasant, but the early stages of the hypomania, when they have all this energy and this mental power and they are super productive and they make jokes with everybody and they write a paper and they do this and they do that, it's good, but the problem is that it's not sustainable. We go back to these fluctuating states, to this change state. Anything that's too fixated, too rigid, it's indicative of illness. So that's why I was telling you, we cannot be happy every day because that's not a sustainable state. We have to adapt. We all change. So in mania or hypomania, when someone recognizes that maybe I'm sleeping my usual time, I usually sleep like 8 hours or so, but then I feel like 5 would be okay because I really have to finish this project and I have this new idea and I want to travel. You have to be very aware of your early warning signs. One of the earliest one is sleep. Again, that's one of the trickiest one. When you feel that, let's say, you are not sleeping that much and you are like on a lot of coffee, you feel like you are super energetic, one of the things that will help is to decrease stimulation. And by that, I mean, if you're already kind of revved up, don't go to the mall. It will be noisy, it will be people. You have to decrease the stimulation, okay? You don't need to spend the money that you don't have, because if you're in a hypomania or mania, everything is easy, it's fast, this is great, why not? No, so you have to put the brakes on, and usually your relatives are very good at telling if you're okay or how are you doing, because they will realize that there is something else going on. One of the things you have to do again is to decrease stimulation. Sleep, we talked about how important it is to be preserved, and you have to plan ahead. For example, if you travel to Europe or to Asia and you know that these trips can be kind of unsettling for your system, you have to plan ahead in terms of contact someone, for example, in your family, or having not all your credit cards available, or knowing that you'll be back in 3 days and that you can contact your doctor. So you have to plan ahead. Usually in mania or hypomania, because people have this kind of craving for stimulation and for new things, and everything is fun, people will get into drugs, and that's probably one of the worst things you can do. Basically, because it will worsen the whole picture. Because you can add, cannabis or alcohol to the picture, and then you will end up crashing really bad. Not only because the mania is not sustainable, but also because adding more substances to an already fragile system will just be too much for it. So you have mania, and most of the patients will enjoy the first weeks, let's say, of hypomania. Let's say that you don't go to a mania, you are not psychotic, but you're having fun. You realize that it was not okay, but you didn't call your doctor because you were fine. But then you get depressed. And that depression, the post-mania depression, the crashing depression, is really difficult to treat. Why? Because you had a hypomania prior to that episode. So it was like a two-phase episode, not only the depressive one, but you crashed. Imagine that you're on a plane, and then you can usually land very softly after a mania or hypomania. That can also happen. But usually, because all these energy expenditure, people crash, and that can be very dangerous. So know your signs, and know that if you're going to travel to Europe, for example, and you're kind of happy or hypomanic because it resets your mood, you have to know your triggers. And that's all for me. I want to thank my team for helping me.